Okay, so today in Unplugged series, I'm going to discuss a very common topic, that's a GCS, Glasgow Coma scale, but it's very important. Every year in one or the other exam, you'll see that one question is very frequently asked from this. So I'll discuss the basic GCS and I'll tell you what the new changes uh, they have. We find the new changes and what is the pediatric GCS, and then we have a Glasgow outcome score. That's for the recovery after trauma. So as far as the basic GCS is concerned, so I'm going to discuss GCS and the changes, the new concept. As far as the basic GCS is concerned, this is, I'm sure you know, this is divided in three categories. EVM, eye opening, verbal response, and motor activity. So eye opening is from E1 to E4, verbal response V1 to V5, and motor activity M1 to M6. So eye opening, the four simple, numbering the score is no response is 1, to painful stimuli 2, to verbal command 3, and spontaneous eye opening 4. So nil, no response, painful stimuli, verbal command, and spontaneous. Now verbal response. You talk to the patient, see the response, whether he's able to speak or not, and whether it's comprehending, he's communicating, he's talking rational, he's talking irrelevant. So verbal response is from 1 to 5. 1 is no response. 2 is incomprehensible sound, like he's crying, he's wincing, he's moaning, he's only producing sound. He's not saying any word or sentence, just sound. Third is he's using words like but it's inappropriate, only words. Fourth, sentences. He's making sentences, but he's disoriented. He's not answering your question. You're asking something, he's saying something else, but he's making sentences. And 5 is oriented and converse. So 5 is oriented, 4 is disoriented, 3 is inappropriate, 2 is incomprehensible, and 1 is no response. Now motor response, 1 again is no response, no activity whatsoever. 2 is extension, decerebrate. Patient lies in this position, in extension position. Extension simply means that there is a transaction from midbrain. The cortical inhibitory function is gone now. It's complete transaction midbrain level or pontine level. So 2 is extension. That's called decerebrate. 3 is flexion, decorticate. Patient lying like this in flexion state. 4, flexion withdrawal. Like you give a painful stimuli. Suppose I press here, supraorbital nerve, patient is unconscious. He'll take his head away from the painful stimuli. If I pinch here on the arm, I give painful stimuli, he'll move away his hand in flexion. Flexion, withdrawal, he can perceive the painful stimulation. 5, localizes pain. Suppose I pinch here and he takes his head away, that's 4. But he brings his hand and tries to move away my hand, means he's able to localize where the painful stimuli is being given. That's M5. So that's localizes pain, and M6 is obeys command. So no response, extension, that's decerebrate, flexion, decorticate, flexion, withdrawal, localizes pain, and obeys command. Now mild head injury is 13 to 15, 13, 14, 15. Moderate head injury 9 to 12, severe head injury less than 8. Less than 8 is an indication for intubation, and less than 8 also is an indication in some cases for intracranial pressure monitoring, ICT monitoring, normally done when the GC is less than 8. The patient who are intubated, they cannot produce voice, they cannot talk, they cannot speak. So for them we use the term VT, V endotracheal tube, VT. We don't give number 1, as I've seen in some books, some internet site, they've written 1. No, it's just VT. So now we will do the GCS scoring from 3 to 10 rather than 3 to 15. And in front of V, we'll write T. So that will be, minimum will be 2, maximum 10. Normally minimum is 3, maximum 15. V becomes T. An intubated patient, the maximum, as you can see in the last line, GCS score T, 10 T tube to minimum 2. Now this basically, what I said that if the score is 3 or above, means cerebral injury must be above the midbrain, somewhat in the internal capsule cerebral hemisphere. And if the score is 2 or below, then it is basically, there is a inhibitory fiber which are gone. So disinhibition of vestibulo spinal tract and pontine reticular formation. The inhibition is usually at the level of medullary reticular formation, it's transected, or intracollicular level between vestibular and red nuclei. This diagram is showing you the changes. Now let's come to the new changes, the concept. What has changed, what has come up new. Firstly, Glasgow Coma scale was given in 1974, and that time it was only 14, not 15. So, the flexion withdrawal, abnormal flexion was, corticate was not there, flexion was not there. This was added in 1976. So that's why sometime it said modified GCS. Modified GCS was basically what GCS we discussed from 3 to 15. Original GCS 1974 was 3 to 14. So this flexion was added 3, M3 was added later on, it became modified GCS. The second change that has happened of late, that happened in 2014, here everything is same, only the terminology changes. Now in E2, eye opening 2, rather than pain, we call it pressure, 2 pressure. No response 1, to pressure 2, eye opening. And to sound, we call it to speech, to verbal response, verbal command. So rather than pain, you say pressure, and rather than sound, you call it speech. So eye opening 2 and 3, the word has changed. And the second change that has happened in terminology is verbal response. So V1 is none, V2 was incomprehensible, and V3 was inappropriate. Now the terminology is much simpler. V2 is sound, V3 is word. Like he is only producing sound, which was incomprehensible terminology. Now we call it to sound. He is only producing sound, V2, and he is producing words. He is saying some words, but not sentences, that's V3. And he is saying sentences, but is confused, that is V4, and oriented V5. So rather than incomprehensible, now the term is sound, and rather than inappropriate, now the term is word for V2 and V3. So another new change that happened in 2016, in GCS now, pupil has already been added. So we have added pupil also. So this diagram shows the change that has happened with red color. So rather than pain, you call it pressure, and sound and word. Then you add pupillary response, pupillary score also, whether pupil are responding to light or not. If they are responding to light, you give 0 number. That's a normal pupil. If not responding to light, 1 pupil, 1 number, 2 pupil, 2 number. So pupils are dilated, not reacting to light, one side pupil, 1, both side pupil, 2. And whatever GCS you have, you reduce the pupillary score, you subtract, you deduct the pupillary score, and then you get the final GCS. Like we have GCS 9. Let's say someone having GCS 9. And 1 pupil is not responding to light, so that's 1 number. So we will reduce from GCS 9 minus 1, so the score now will be 8. If both pupils are not responding or dilated, then the 2 numbers. So from 9 we'll deduct 2, and the score will be 7. And if the both pupils are normal, responding to reacting to light, then it is 0. So GCS will be what normal GCS 9 you have, so 9 will be here. So either 1 or 2, depending on the 1 pupil not responding or both pupil not responding, you will deduct this number from the GCS, and then you get the final score. That is GCS pupil P. So this is a 2016 change. Now pediatric mein only thing that will differ, that will be different, that will be difficult to do, is the verbal response. A small child will not follow command or cannot speak, he'll only cry, he'll produce sound. So eye opening remains same, no eye opening to pain, which you call as pressure now, to speech and spontaneous, that's eye opening. Verbal response, no response 1, he is only producing sound, like he is moaning to pain. 2, he is crying to pain. 3 and 4. Now the word here is cries to pain and irritable cries. You can add one more word, inconsolable. 3 is he is crying and you cannot soothe the child. He is inconsolable. You are not able to give comfort to the child. While in 4, he is consolable. He is crying irritable. In between, he is crying, in between, he is somewhat normal. So inconsolable or consolable, that's 3 and 4. And his normal coos and babbles and normal, sounds, that's 5. Now coming to motor response, again it's same with very minor difference. No motor activity 1, extension 2, flexion 3, which is in adult as well. Flexion withdrawal, now here 4 and 5. 4 is withdraws to pain and 5 is withdraws to touch. So if you touch and he doesn't move his hand, that's 4. Only on painful touch he is moving, or he moves with touch, that's 5. So here 4 and 5 is a little different from adults. In 4 you have flexion withdrawal, in 5 you have localizers pain, and here 4 is withdraws to pain and 5 is withdraws to touch. So pediatric, very little difference, minor difference, none. Verbal response, moans, I is same, moans to pain, cries to pain, inconsolable cry, consolable cry, irritable cry, intermittent cry, that's 4, and normal babbling and normal, verbal responses 5. Motor activity, no activity 1, extension 2, flexion 3, same, withdraws to pain 4, withdraws to touch 5. So that's the difference. Now finally another score, which is a relatively important score, it may be asked, that's Glasgow outcome scale. That is not for head injury, that's for recovery. After head injury, normally 1 year is the time, and then you can assess the recovery. So a scale by the objective degree of recovery is called Glasgow outcome scale. And again you have 5 scales: good recovery, moderate disability, severe disability, vegetative, or dead. Good recovery does not mean absolutely 100% normal. Good recovery, he may have some psychological impact, he may have some emotional impact, or very minor neurological deficit. Some tremors is persisting, so minor. But he is able to do normal job, what a normal person can do. He has normal family relationship, leisure activity, everything normal. So whatever neurological deficit or psychological deficit there, that's not interfering his lifestyle. Moderate disability, now he has certain residual neurological or emotional or significant intellectual or memory deficit. So he may have ataxia, he may have a bit of dysphagia, he may have intellectual memory loss. So he cannot drive, he cannot use two-wheelers, but he can use public transport and he can work under supervision. So in selected supervised environment he can work. Severe disability, now he is disabled. You can say he is dependent. So there is a definite physical, mental disability or both. So he is dependent on his day-to-day activity. In moderate disability, he is not dependent on day-to-day activity. And then severe disability dependent, 4th is vegetative, and 5th is dead. So this is the Glasgow Coma scale. So few new changes that has happened. One was in 2016 they have changed the terminology, 2014 sorry. In verbal response, from incomprehensible we call it only sound, and inappropriate we call it word. And eye-opening to pain, that's 2, we call it to pressure, and 3, that's to sound, we call it to speech. And pupil also, this is a new change. So GCS is very important topic. Everywhere I see question from one or the other exam. So that's it. And you can follow our damsdaily.com on YouTube. This is very important update you'll get repeatedly here. So that's it. We'll meet again next time with some new topics. Thank you.